Wow, really terrific cases. I mean, these cases are now open for discussion. Maybe I'll start with you, Manos. I mean, you're known internationally as one of the best coronary operators. Give us your thoughts on these three cases, really kind of different strategies used, different problems that were being solved. What are your initial thoughts about this?
Thanks, Sunil. I do agree these are all phenomenal cases. The first one, doing essentially single access for VECMO is a unique application, very similar to what we do for Impella routinely right now. So I really loved that case. The second case was something unique. Having a fistula is something we don't see very often. And using the unplatzer duct occluder to seal it is something that worked great. And I think it's an option for people who have similar fistula. And the third option is a good reminder in my mind of how a simple diagnostic cath can lead to a disaster and how to best approach it, being very careful. Don't inject. And if you have this, then stop injecting, get a wire through, and then stent the lesion, which the authors did in a very good way. So I think all of them provide a unique perspective, and they're all very well done.
Yeah, and we do have the presenters that are here. So if we have questions or comments about the cases, please ask. Paul, you had mentioned, I think, offline when we were watching these cases that the second case in particular, the fistula case, sort of blurs the lines between structural and coronary. This may be a little bit more of a philosophical question, but are these dichotomies a little bit false now? I mean, is the future interventional cardiologist going to have to learn how to do all this stuff?
Oh, no, I was making the comment more out of jest than anything else. As many of you know, I'm structurally focused, but I also do coronaries as well. And I think it does show, I think, the importance of cross-fertilization. And I think for those of you who are earlier in your training or careers, or even now, thinking about what you can learn from other specialties, I think it's very important. I think, in ADO, we weren't the first to use vascular plugs in the vascular space. That was a peripheral thing, for AV fistulas. But the structuralists have readily adopted that to do structural closures. And you see now, you can also use it to close coronary fistulas. So there's also a lot of potential cross-fertilization between our specialties or areas of focus, I should say. And I don't think we need to be pigeonholed into one area or another per se, but always be open to other ideas across these different areas of focus.
So Mehdi, I think the first case really illustrates very nicely how creativity can really help us reduce complications. I mean, I think we know that the more sticks a patient gets, the higher the risk. So it's a really creative solution to use single access. Tell me a little bit. I mean, you do a lot of peripheral work. Tell me a little bit about, have you seen the complications from these large bore access? Have they gone down over time? Are they staying stable? Have you been called on for, putting in sort of sheets to help integrate perfuse limbs in these patients who are really very, very sick and require mechanical support?
Yeah, thanks, Sunil. And I was going to ask a couple of quick questions from the presenters, if you give me
please.
But I'll answer that. As you know, yes, obviously the rates of complications have gone up, but I am very happy and look forward to the fact that many interventionalists are now involved with placing these large bore ECMO and Impella devices. I think Impella is given, but even ECMO, as you may recall, ECMO was really for the surgeons to do. But in the last 10 years, I think we have gotten more involved. And I think for us to place anti-grade sheet and perfuse the limb is much easier, especially using fluoroscopy and not doing these procedures at the bedside. So, Naveen, I really enjoyed your presentation. I wanted to ask you one quick question related to air entrapment. I always get very nervous when we are, have this circuit, and the idea of putting a guide through the Y adapter and potentially getting air inside. So did you turn off the ECMO during the intervention, or did you have it at a very low rate? How did you make sure that you didn't accidentally trap air while you were manipulating the guide and those kind of things?
Yeah, it's a great question. So I think that what we're seeing is in these types of cases, we have to actually go down to the OR and learn how to do this with our surgeons. So surgeons actually do this pretty commonly. They'll go ahead and clamp, get different Y connectors in. We do that when we're doing biatrial ECMO, when we're doing VVA or VAA configurations. So in the cath lab, we're getting quite comfortable with the idea of inserting Y connectors. Now with this patient, and in particular, because we were now using a dry seal sheath as the side access site, The dry seal actually is really nice in this configuration because it allows you to have hemostasis. We obviously de-aired the system prior to inserting anything, but the patient's on full ECMO flow. And we've now done about 5 or 6 of these cases. One of the most recent ones was in a COVID patient who'd been on VV ECMO for about 4 to 6 weeks and actually couldn't tolerate being off of VV ECMO for more than a few minutes before they developed severe cardiac compromise. So in that patient, it took us about 1:38 to put the system in and also de-air the system. With the dry seal, we can now go in and put a sheath without actually introducing any air. It does need to be done carefully. There is also a side port off the dry seal, which allows you to go ahead and make sure that you're continuously de-airing if you do see air in the system. But I do think that it is, this is something that's coming off the shelf. ECMO right now is not designed for the interventional community. And if we're going to be doing more ECMO in order to enhance safety and efficacy of the technologies, we have to have ECMO systems that are designed by interventionalists for interventionalists. And this is sort of the first step towards developing a TUI-like system that you can splice into an ECMO circuit, leave the patient on full flow, and do your subsequent interventions.
Wonderful. Thank you.
Yeah, that's a great comment, Naveen. Subhash, questions for the presenters?
I had one quick question. I think my colleagues have asked them already. My first question was where to find this Y connector. I think Naveen answered it. The second one would be how is it possible, is it easy to actually visualize the actual fistula through a antegrade injection? And I saw a still picture, but I'm not entirely convinced that it is that easy to visualize. And maybe Paul can jump in after the presenter has a comment. And for the last question is that I'm just going to challenge you is that you have an RCA dissection, you don't know what the left anatomy is, and you launch yourself into a long, complicated RCA intervention. Now, one could agree, one could also argue that it might not be improbable to actually look at the left, because you may find something so bad that you might actually want to change the course of the patient's treatment plan. Or if your procedure does not go well, you will not be committed deep into it. So I think those are the thoughts, I think, there's a different ways to skin the cat, but I just want to have you answer to those.
So Dr. Kalik, why don't you start? So how easy was it to visualize this fistula when injecting the coronaries?
I think we were really surprised when we got the injection, and when we see the large fistula, we were really surprised. But upon the history of the patient, because she had a failed attempt in 2017, and they tried to occlude that fistula in an antegrade way from the left main coronary. They tried to go from the LAD, and you just appreciated the extensive tortuosity of the fistula. So we did not even try to go antegrade from the LAD, proximal part of the LAD. So we just try to find a new solution. And while like the retrograde CTO procedures, we just injected from the left main, and just we tried to see the distal neck of the fistula, which was communicating to the pulmonary artery. And somehow it worked.
I saw Manos get excited when you said something about retrograde there, but we'll let Dr. Chowdhury. What about that? What about taking a breath and injecting the left to see what's going on there?
Yeah, that's a great question, Dr. Banerjee. I think we considered that for a few seconds, and then patient was really sick, and we thought we stabilize the patient, which we did medically with vasopressors and such. And the next step was, you can look at the left and think about cardiac surgery. We did call the surgeons as soon as they recognized the dissection, knowing that we may have to take that route. But we also wanted to give it a try to see if we can actually open the vessel restore flow and stabilize the patient that way. But
I appreciate you didn't take my bait. Perfect.
Great.
No, but like as you said, you could have done it like you said. That's totally different way to do this, and completely fine. Probably would have turned out okay.
So one last question for Dr. Chowdhury. You did have the IVUS that showed that you were in the true limb. Did you consider using the IVUS to figure out where to land your stents and just go with stents directly rather than try to balloon again?
We did, and we kind of looked at the IVUS a few times, to see if we can figure out where the dissection started and where it actually ends. So we know exactly the segment we needed to cover. And despite a lot of trying, we could not really pinpoint exactly where the dissection ended. He kind of can get a sense of where it might have ended. So we thought that we wanted to restore flow into the vessel as soon as we can. So that was the rationale behind ballooning the distal portion. And then once we have ballooned it, we kind of have thought that we needed to stand that right as well. And the dissection did propagate all the way down to at least the mid, maybe even the distal section of the RCA.
Great. Well, congratulations to all three of you. Really terrific cases. We're going to move on now to the peripheral cases. These are going to be presented by Dr. J.D. Corral, Dr. Ashkan Karimi, and Dr. Sandeep Shenoy.